Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Paul Ragusa from Westchester, New York, United States. Dr. Ragusa is a consultant orthopedic surgeon specializing in shoulder and elbow surgery at the St. John's Riverside Hospital in Westchester County, New York City. After completing his orthopedic residency at the Hofstra Northwell School of Medicine in Long Island, New York, he pursued a fellowship in shoulder and elbow surgery at the Johns Hopkins School of Medicine and Johns Hopkins Hospital in Baltimore, Maryland. Dr. Ragusa is a member of the American Shoulder and Elbow Surgeons Society and also the American Academy of Orthopedic Surgeons. If you've noticed, Dr. Ragusa has delivered a lecture on our channel in the past, which has already reached to a huge audience. And today it's my great honor to bring back Dr. Paul Ragusa for this wonderful live program. Over to you, Paul.
Thank you again, Dr. Gopalan, for the invitation to speak today on arthroscopic rotator cuff repair, single row, double row, and a transosseous equivalent repair. I have nothing to disclose. This presentation is based off of a textbook chapter that was authored by myself, Dr. Ankit Bansal, and Dr. Uma Shrikumaran, while at Johns Hopkins Hospital School of Medicine. The textbook provides concise summaries of common shoulder pathologies, treatment options, and I do not receive any royalties from this book. So we'll get into it. The goal of rotator cuff repair is to obtain secure, tension-free fixation of the tendon to the anatomic footprint so that biologic tendon to bone healing can occur. Open transosseous rotator cuff repair had been considered the gold standard technique and has performed well in clinical and biomechanical studies. The transition from open to arthroscopic repair has brought about an evolution of techniques that include single, double row, and more recently transosseous equivalent or suture bridge repair. And the optimal technique is still controversial, and the superiority of one construct over another is not well established. Single row repair utilizes a linear row of suture anchors, typically double or triple loaded, inserted into the medial or lateral aspect of the rotator cuff footprint, depending on tendon mobility. Suture anchors inserted at 90 degrees to the surface of the rotator cuff footprint have been shown to have less gap formation and increased cyclic load to failure when compared to those inserted at the deadman's angle of 45 degrees. Suture limbs are passed through the tendon in a variety of suture configurations, whether it be simple mattress, modified Mason-Allen, or lasso loop, etc. The advantages of this technique are that it's quick, it's easy, and it does not require a lot of or a large amount of residual tendon length. The disadvantages are that it's less anatomic, it's inferior biomechanically in vitro, and it's subject to mechanical failure. And for single row repair, it's recommended that we use this construct in tears where there's less than 1 centimeter of remnant tendon length. And most published data suggest that a single row repair is sufficient for small and medium-sized rotator cuff tears, those being less than 3 centimeters. Double row repair was introduced by Lowe and Burkhart in 2003, and it involves placing a medial row of suture anchors along the humeral head articular margin and a second row of anchors on the lateral aspect of the rotator cuff footprint. Suture limbs from the medial row are passed about 5 millimeters distal to the musculotendinous junction in a mattress configuration. Lateral row sutures may be passed in a simple or mattress configuration, and care must be taken to avoid overtensioning the repair, and this can be achieved by assuring that adequate tendon length and excursion is available. An advantage of this technique over single row repair is that it's biomechanically superior to single row in vitro. It provides improved footprint restoration and contact area at the tendon bone interface, which theoretically allows greater surface area for tendon to bone healing to occur. And there's an increased healing rate that's noted on imaging studies. Disadvantages of this technique include increased cost, which is associated with materials and increased operating room time. There's increased difficulty, and there can be anchor crowding in the footprint, which can make revision surgery difficult. And importantly, there's been no proven clinical benefit on outcome scores. So most published data suggest that double row repair may be preferable for large and massive tears with adequate tendon length. And significant tissue loss or remnant tissue on the lateral footprint precludes the use of a double row construct. Transosseous equivalent repair was introduced by Park et al. In 2003. It's also known as a suture bridge repair, and it's a modification of the double row where the medial row suture anchors or suture limbs are linked to knotless anchors on the lateral humeral cortex. And it's different from the double row repair where each suture anchor acts as a separate point of fixation. One advantage of this technique is that it's been shown to improve load to failure compared to double row. In addition, since the lateral anchors are inserted in the lateral cortex as opposed to the lateral footprint, it avoids the problem of suture overcrowding in the footprint, which we can see with the double row repair. The interconnection between the anchors leads to improved load sharing against rotational forces. Another advantage is that it provides a broader surface area of contact, similar to a transosseous traditional open repair. And this differs from the spot weld fixation that we see with double row repair. And you can see that on the figure on the right, you have that spot weld type of contact and a more broad surface area with the transosseous equivalent technique. So a major disadvantage to using this technique is that the vascular supply to the tendon may be compromised by increased pressure over the bursal side of the tendon. Tuberosity crowding with theoretical risk of iatrogenic tuberosity fracture if the anchors are not spaced appropriately. And in addition, passage of medial row sutures through the musculotendinous junction should be avoided because of the risk of medial row failure, and we'll talk a little bit about that later. So we'll begin by looking at the biomechanical studies of these different techniques, and my hope is to really summarize the data that's out there. But before looking at the studies, it's important to understand the biomechanical properties necessary to achieve successful rotator cuff repair. And this was described by Cole and include a high initial fixation strength, which is measured as an ultimate load to failure, minimizing gap formation at the time of repair, maintaining mechanical stability under cyclic loading, and optimizing the biology of the tendon-bone interface until healing occurs. Several technical parameters have been used to affect rotator cuff repair strength and achieve these biomechanical properties, including modifying suture anchor configuration, which we've been talking about with the single row, double row, and transosseous repair techniques, but also modifying suture configuration. In other words, putting something, the suture limbs in a simple suture versus a mattress suture or a modified Mason Allen. And lastly, altering the number and the type of suture used. So regarding suture anchor configuration, there are several biomechanical studies that have shown superiority of double row to single row repair with regard to mechanical strength, footprint coverage, and gap formation. The study by Kim et al. Found that Adding a medial row of anchors increased the stiffness of repair by 46% and the ultimate failure load by 48%. Baums found that double row repair achieved a mean load to failure similar to that of healthy tendon, whereas single row repair reached only 70% of the load of a healthy tendon. Mazzacca found a significantly greater supraspinatus footprint width was seen with double row techniques compared to single row repair. And Ma found that the ultimate tension load was significantly higher for double row fixation than for all of the single row fixations in their study. There are some biomechanical studies to support suture bridge or transosseous equivalent repair over standard double row repair. Transosseous equivalent has been shown to be superior to double row repair by providing a larger area of contact pressure and a higher ultimate load to failure. And the mean load to failure was significantly greater for transosseous equivalent compared to double row repair. You can see this 443 newtons versus 299 newtons. Gap formation during cyclic loading, on the other hand, was not significantly different. And the conclusion of these papers were that transosseous equivalent repair helps restore footprint dimensions and provides a stronger repair than double row techniques, which may theoretically optimize tendon healing biology. But the question still remains that, perhaps it's not the suture anchor configuration, single row, double row, transosseous equivalent, that makes a difference, but rather other technical parameters. And perhaps no other paper better summarizes this point than this recent systematic review of 40 biomechanical studies, which conducted a meta-regression analysis to identify the technical and procedural parameters that most strongly predict biomechanical performance of rotator cuff repair. And these are the, it's a busy slide, but this is these are the variables that they looked at, not only suture anchor configuration, but the type of suture anchor, the number of suture bridges, the number of mattress sutures, etc. And their findings suggest that the type of suture and the number of sutural limbs that pass through the tendon may be stronger predictors of fixation strength than the construct type. And 4 major findings were revealed. The first is that, again, the number of suture limbs passed through the tendon may be a stronger predictor of ultimate failure load than the number of sutures used. Although transosseous equivalent repair achieved the highest ultimate load to failure, as seen in this graph on the right, there was no significant difference found between repair types when stratifying by the total number of suture limbs that passed through the tendon. The third point is that a higher number of suture limbs that passed through the tendon and the use of transosseous equivalent repair increased the risk of developing a type 2 re-tear, and we'll talk about what that is. And using wide sutures instead of standard sutures correlated with a higher failure to load. So next we'll look at functional outcomes and see if what's seen in the lab translates to what's seen in our patients clinically. And what we see is that in contrast to biomechanical studies, the literature looking at functional outcomes of different repair constructs is less clear. These are several level 1 randomized controlled trials evaluating clinical outcomes after single row and double row repair, and they have not found any significant difference between the two techniques, at least at short-term follow-up. In addition, these are several meta-analyses that have also reported no differences in clinical outcomes between single row and double row repair. However, there is some evidence to suggest clinical superiority of double row repair over single row repair when performed for larger rotator cuff tears. This is a level 1 randomized controlled trial of 160 patients with full thickness rotator cuff tears And they found superior clinical outcomes at 2 years with double row repair compared to single row repair, especially for tears greater than 3 centimeters. The chart on the left are the results of their repairs in tears less than 3 centimeters, so small and medium-sized tears. And the one on the right is for larger tears greater than 3 centimeters. And in the under 3 centimeter group, the double row repair showed significant improvements in motion and shoulder strength index. In the chart on the right, in tears over 3 centimeters, the UCLA and ASCS scores showed significant differences, and the shoulder strength index and range of motion also showed significant improvement in the double row repair group. This is a level 2 cohort study, Park et al. They looked at 78 patients with full thickness rotator cuff tears, and those with tears greater than 3 centimeters, again, were found to have significantly improved subjective outcome scores, that being constant and ASCS scores, and significantly improved shoulder strength at 2 years after double row repair when compared to single row repair. However, no significant differences between the techniques were found when all tear sizes, including those less than 3 centimeters, were included. So this study lends to the fact that maybe it's the tendon itself that's more of a predictor of success than the construct or other technical parameter. This is a level 2 randomized controlled trial of 53 patients with an initial tear size of 3 centimeters. And they found that undergoing single row repair and double row repair with a minimum of 2-year follow-up showed that patients who had initial tears greater than 3 centimeters in sagittal length had improved strength at 2 years when treated with double row compared to single row. These are 2 recent meta-analyses, relatively recent meta-analyses, that also indicate potentially better clinical outcomes with double row repair in patients with tears with a size greater than 3 centimeters. And although there are several studies, now we're talking about transosseous equivalent repair, although there's several studies which show successful clinical outcomes with suture bridge repair, there's no studies that show superior clinical outcomes of this technique over double row or other techniques. So again, there's a difference between the what we see in the biomechanical studies versus the clinical studies. So next we'll look at the structural outcomes, or in other words, the presence of a structural failure or rotator cuff re-tear. And before we look at the data, it's important to note the types of re-tear patterns which can occur. And Cho described these two patterns of rotator cuff tears. In a type 1 re-tear on the left, failure of the tendon occurs at the site of repair, often with the tendon detachment from the bone. In contrast, on the right, in a type 2 re-tear, failure occurs medial to the repair at the musculotendinous junction, and this leaves behind remnants of the tendon still attached to bone. And so these are 2 cartoons. These are the 2 correlating MRI images with these re-tear patterns. And on the left, we can see that in a type 1 re-tear, we know that the weakest part of the suture anchor repair construct is at the tendon suture interface. And the most common mode of failure is the suture cutting through the tendon, not necessarily the anchor pulling out of the bone. The mechanism of failure of type 2 re-tears, and you can see that on this picture on the right here, where you have residual stump of tendon in the footprint and the tendon tear occurring at the musculotendinous junction. The mechanism for this type of tear has been attributed to tension overload at the musculotendinous junction of the supraspinatus. And therefore, it's important to remember not to pass these sutures in a double row or transosseous equivalent construct too close to the musculotendinous junction as to not overload this part of the tendon. And these type 2 tears are associated with a worse prognosis than a type 1 failure. The incidence of re-tear after rotator cuff repair varies widely in the literature, and historical estimates range from 11% to as high as 94% in patients with larger and massive rotator cuff tears. This is a classic study using ultrasound to evaluate cuff integrity, and it found that a re-tear incidence of 94% after single row repair of tendons measuring greater than 2 centimeters. And when looking at the functional outcomes, although the 12-month evaluation showed excellent pain relief and range of motion, at 2-year follow-up, the results deteriorated with only 12 of their patients having an ASES score above or equal to 8. And despite its high incidence, the clinical relevance of rotator cuff re-tear remains controversial. Although some studies suggest that repair integrity does not affect clinical outcomes, several studies, as shown on the right, have shown that re-tears do affect functional scores. Ruel Kim found that pain, visual analog score, UCLA score, and absolute and relative constant score in the completely healed tendon was significantly superior to those in the re-tear group. Park found in their study that temporary decrease of abduction strength at 6 months in those that had a re-tear. Sethi found that strength was the only clinical finding that differed between intact and non-intact tendons. Hontes found that perhaps that patients with healed tendons demonstrated superior clinical outcomes as measured by the UCLA and constant score when compared to those with retorn tendon. And Liam found that patients who had a re-tear had significantly less abduction strength and significantly lower total constant scores than those who had an intact rotator cuff repair. So patient age, initial tear size, and fatty degeneration are independent risk factors for a rotator cuff repair. I'm sorry, for a rotator cuff re-tear. Consistent with biomechanical outcomes, multiple systematic reviews and meta-analyses have reported that re-tear rates are lower for double row versus double row repair. I'm sorry, double row versus single row repair. And similarly, studies have shown superior healing rates of transosseous equivalent repair compared to single row, particularly for larger and massive tears. However, the re-tear rates of small tears less than 1 centimeter do not appear to differ between transosseous equivalent and single row techniques. And to date, no level 1 study has shown that transosseous equivalent technique yields superior healing rates compared to conventional double row or single row repair. Now, and the study on the left is a recent systematic review, and they found that the re-tear rates of double row and transosseous equivalent repair did not differ significantly from each other in any of their tear size categories. And so, getting back to the re-tear pattern, the question is there an association with the suture anchor configuration used to the re-tear pattern that we see? And the answer is yes. Type 1 re-tears are typically seen after single row repairs, and type 2 re-tears are typically seen after transosseous equivalent and double row repairs. And several studies suggest that excessive tissue contact pressure and tension overload in the medial row repairs cause strangulation of that microcirculation on the bursal surface, resulting in reduced blood supply to the tendon and ultimately failure. Recent studies suggest that transosseous equivalent repair construct alone may not be responsible for the type 2 re-tear pattern, and techniques used to decrease overtensioning at the musculotendinous junction, such as leaving the medial row sutures untied and bringing them over, or using rapidly absorbable suture on the medial row, may lead to a lower rate of type 2 failure. And by that, we mean basically that, in the image on the top here, these sutures have been tied and brought over. That's a much stronger construct, theoretically, than if you were to just bring the suture overs over to the lateral row anchors without tying them. And perhaps that may result in a lower type 2 failure rate. And why is this significant? Because revision surgery in the setting of a type 2 tear is difficult, and the options are limited compared with type 1 tears, especially considering the fact that there's multiple anchors that are being used for these repairs at the initial surgery, and the real estate is not very large. So revision options for type 2 tears are likely to rely more on tendon to tendon healing as opposed to tendon to bone healing that we see in the type 1 re-tears. And again, type 1 re-tears, they don't result in loss of tendon stock, and as a result, they can usually be repaired again to the anatomic footprint. So in conclusion, the goal of rotator cuff repair is to obtain secure tension-free fixation of the tendon to the anatomic footprint so that biologic tendon to bone healing can occur. Arthroscopic techniques include single row, double row, transosseous equivalent repair. And the optimal technique is still controversial, and the superiority of one construct over another is not well established. Several biomechanical studies have shown superiority of double row and transosseous equivalent repair over single row repair with respect to mechanical strength, footprint coverage, tendon to bone contact pressure, and gap formation. And a recent systematic review of these biomechanical studies found that modifying the number of sutures, suture limbs, and mattress stitches in a construct are stronger predictors of fixation strength than the construct itself. Despite biomechanical superiority of double row over single row repair, several level 1 studies evaluating clinical outcomes have not found any significant difference between the two techniques at short-term follow-up. And some studies suggest superior clinical outcomes with double row compared to single row for, again, tears greater than 3 centimeters. Tears less than that, it's likely not, it does not make much of a difference. Consistent with biomechanical outcomes, multiple systematic reviews and meta-analyses have reported that re-tear rates are lower for double row versus single row repair. However, the clinical relevance of a rotator cuff re-tear is still remains controversial, and type 2 re-tears are typically seen after transosseous equivalent repairs and have been attributed to tension overload at the musculotendinous junction of the tendon, and increased construct strength of a transosseous equivalent repair needs to be balanced with the higher risk of these type 2 failures. The references from this, many I mentioned in the actual PowerPoint itself, but they can be found in the text as well. And thank you. So we can leave some time for some questions if anyone has any.
Thank you, Paul, for a comprehensive lecture on cuff repair, single row versus double row, and transosseous. A couple of questions. What was your preference in using these? I mean, among these three, what is your preference? For example, would you like to change depending on the patient? For example, you mentioned, suppose it's a larger tear, you would prefer a double row, right? What about age and fatty infiltration?
Yeah, I think both age and fatty infiltration both affect the tendon quality and the ability for the tendon to really the tendon remnant size. So if the tendon remnant size is small, that's not going to lead me to use one of the constructs like a double row or a transosseous equivalent repair just because there's no tendon stock there to repair back to the tendon. So in that case, I would use a single row repair. And those factors do affect that. But I would say that for the larger tears, I would use my preference is to use a suture bridge type technique, as long as there's adequate tendon length. For the smaller tears, to me, it doesn't make sense to, if you have a 1 centimeter tear, to put a, 2 anchors or 1 even anchor into the footprint, a 5 millimeter anchor into the footprint. That's really not going to leave a lot of real estate for biologic healing, even though there's anchors nowadays that are vented and can still, give you some good healing rates. I typically tend to put those anchors more laterally and leave the footprint empty, kind of like the technique described by below, where he just does sort of a tension band technique for smaller tears. It really doesn't, the literature at least shows that it doesn't matter much for small and medium-sized tendon tears what tendon construct, what repair construct you use. It's more importantly, it's the quality of the tendon and just doing a good repair at time 0, and making sure that your knots are tied securely, or if you're using knotless anchors, to do that appropriately as well.
Thank you, Paul, for that. And what about the use of biologics to enhance healing? For example, the use of PRP or platelet-rich fibrin matrix or any of the biologics?
Yeah, so that's an excellent question. And obviously that's a hot topic and something that is being researched more recently. It's not something that I incorporate in my practice at this time. And a large part is insurance companies are not approving it. They're not allowing us to do it, but certainly the research, at least for rotator cuff tears, is pretty variable. Whether you use PRP or BMAC, again, I think the jury is still out, and it remains to be seen if these are beneficial. But I think that the research is sort of getting there, but I think we still need a little bit more data to look at that.
And what is your standard postoperative regime for any of your cuff repairs in general?
Yeah, so that's an excellent question. So, and I didn't mention the rehabilitation in this lecture. It is in the text, but basically it's a pretty standard protocol where we progress from passive range of motion to active assisted to active range of motion, and then finally strengthening. But I can say that for the larger tears, we typically move a little bit slower to the point where I won't start therapy in them for about 4 to 6 weeks until after surgery, and I would just keep them locked up in a sling with very little motion during that time period. For the smaller tears, I'll have them moving a little bit sooner, and I think the Moon Group has kind of showed with their two protocols that you can sort of stratify patients based on the repair type. You can accelerate one group that has smaller tears, good tendon quality, versus one that is in an older patient that has poor tendon quality, and maybe keep them, have them progress through that protocol relatively slower. And typically, I don't do strengthening for about, formal rotator cuff strengthening for about 4 or 5 months in those larger tears as well. Just again, because we know that that's kind of that time period where these re-tears can occur.
Thank you, Paul. I think that's all the questions that we have for this session. Fantastic lecture, very comprehensive, and I'm sure this lecture is going to benefit a lot of people all over the world. Thank you so much for joining in, Paul.
Thank you very much for having me.
Bye-bye.